A 31-year-old female who had complaints of headache followed by vomiting, and MRI evidence suggested interventricular hemorrhage, as it is well seen on these images. We performed a DSA. The right ICA, the anterior vessels, appeared to be stenosed and hypoperfusion was there. A lot of basal collateral formation was there, slow flow in the MCA branches, and very distally, near the ventricles, we could see an aneurysmal change in this collateral vessel. Vertebral artery injection again showing a lot of collaterals coming to the MCA. Lateral view shows collaterals to the ACA as well as MCA. We performed 3D imaging to understand there's a very tortuous vessel which was going towards the aneurysm, which formed a very tight loop in its course as seen by the arrows. 2D imaging in the same angle. This is the vessel we could trace leading to the aneurysm. And again, DSA showing how it was tortuous. Now we plan to do microcatheter placement followed by glue injection. This is a magic 1.2 FM being navigated slowly. The problem was in this tight loop, the microcatheter was getting stuck. And the challenge was how to cross it. In the other angle, AP angle, you can slowly with the wire, we massage the microcatheter to make it move ahead slowly through the loops. And then we even changed the wire, gave a different shape, and slowly straighten this loop so as to cross with the microcatheter. So these are very gentle. If you push wire too hard, it's easy to perforate the small vessels as well. So slowly through that complete 8-like twist, we could straighten it, and we could take our micro wire and microcatheter across it. And once it goes across, again, we can continue with a previously described like massage technique, where just the to and fro movement of the wire helps in taking these flow directed microcatheters distally. And just with patience, you can see with the wire, we are just straightening the microcatheter, feeding it and pushing it ahead into this very small vessel. And slowly we could reach to the point, because we wanted to do a very selective occlusion. This is the microcatheter injection, now shows the aneurysm very well. Again, but you can see collateral formation. So we want to do a very selective glue injection so as to occlude a very small part of the vessels and let the other collaterals remain patent. Again, dropdown image is showing slow flow in all these collateral vessels. This is the glue injection, very small selective occlusion of the artery was done. Now this is the AP angiogram. Most of the collaterals are still filling well. The lateral angiogram shows collaterals are filling well and the aneurysm was gone. This is zoomed up image showing the aneurysm occlusion and how around that occlusion point various collaterals had already taken over. Thankfully, patient did pretty well. This is the CT scan done the next day, which showed new infarction. So patient had unilateral Moyamoya pattern with extensive perforatal leptomeningeal collaterals, and these patients present with hemorrhage in later years due to aneurysms on these collaterals. And like in our case, super selective microcatheter placement and glue injection can be done while taking care to prevent collateral closure as much as possible.